Okay, good evening, everyone.
Yeah, good evening, everyone.
Okay. Please, is the number a good one to start? Where we are now 9. Is the number okay for us to start?
Yes, please. I think we can start.
Okay.
Yeah, I agree.
Is they'll join, so we can start.
Okay, thank you. All right, so by way of introduction, let me project my slide. See where we can get this started. Okay, so once again, I think my first time of having this interaction with you was this very week, Monday. And after that interaction, I've been given an extra assignment to walk ourselves through platelets. And this assignment was supposed to be taken by Dr. Deganu, but then he's engaged in an equally important function right now. And then he asked me to step in, and if he's able to make time, he would come through and then also add more. And then, of course, he left me in the safe hands of my very own mentor, Dr. Alote. And with his presence here, I know this flight will take off smoothly, and he will guide the flight remotely, and then we'll actually land safely too. So without much ado, I welcome you to this evening's presentation. Again, my name is Emmanuel Sabuava. I'm a medical laboratory scientist at the hematology department in the central lab, Korle Bu Teaching Hospital. We are going to look at platelet structure, their production, and their function. Then we'll try our best to look at the FBCs we have, how platelets are counted, and then the various flagging systems or flags that we have, we get on the platelets. And if time permits, I might touch a little bit on the platelet histograms. Then we see how we can pick some information from there and use it in conjunction with the films we do, and then use that for diagnosis. So it's going to be a brief but a very loaded lecture. I promise you, I'll be leaving some spaces for you to fill in, so that will make this evening's lecture an interactive one. I'll also plead that if you are in a comfortable place, you get a book and a pen, so that places where you would want to add on, you jot it down safely. Then when the mic is opened, you actually add on. I know we are all experts in our respective facilities. We have, many years of experience, and having come across varying cases, you also have some special knowledge to also share in the matter under discussion this evening. So please, your pen and paper is very needed for you to jot down your additions, your corrections where they are necessary, and then also if places that may be a bit cloudy, you will be able to ask questions in those areas when the time is given for that. Thank you so much. Let's dive in. So the objectives of this lecture will capture thrombopoiesis, that's platelet development or platelet production. Then we touch a bit on platelet structure and function. Then, yes, we'll talk a little about some disease conditions that platelet present with, and disease conditions that affect platelet count and function. Like I said, we'll look at the platelet histogram if time permits, and then we'll see how we can troubleshoot some of the platelet count discrepancies alongside noticing artifacts. Okay. If you were part of our lecture earlier in the week, you realize that I started my presentation with a walk through how blood cells are produced immediately a baby starts forming from in the womb. So I mentioned that yolk sacs were the first site of blood production. Then the liver joins, the spleen comes in. Then when the bone marrows mature, the stem cells migrate to these bone marrows, and then hemopoiesis resides there throughout adult life. I would, at a point in time, draw your attention to things that happen, and there are times that the spleen and the liver comes back to take up hemopoiesis function. And when those things happen, it has some effects on the platelet count. So please, you may as well recall this lecture or this slide well, or just, follow me as I follow the slide, as I draw knowledge from the few things I know, and then gradually we hope to make a great meaning out of the whole picture. So let's get into it. We all know for hemopoiesis, when blood cells start developing, just like military recruitment, there are many disciplines or specialties that these blood cells are generated for. So what I mean to say is that when blood cells are being produced in the bone marrow, they are produced for a certain purpose. So depending on what is needed at a particular time, hormones, cytokines, interleukins are released to guide that production of that bloodline. So generally, we have cells that come into two lineages, the myeloid lineage and then the lymphoid lineage. The lymphoid lineage eventually, produce lymphocytes. And then we have the two types of lymphocytes, the T lymphocyte, the B lymphocyte. The myeloid lineage produces a greater chunk of most of our blood cells. So there you have your platelets, there you have your RBCs, there you have your other white cells. So the lineage will be taking our platelet production from, production from this evening is the myeloid lineage. So let's go deeper and look at what is happening in platelet production from the myeloid lineage. Before platelet is produced, like I said, there are signals that are released. Alongside these many signals, the pioneer driver is the hormone called thrombopoietin. In the case of RBCs, we spoke about erythropoietin, which is mostly produced from the kidney. In the case of the platelets, what drives the production of the platelets is the thrombopoietin, and it's produced from the liver and the kidney. When this hormone is produced, it actually signals the bone marrow to start the production of platelets. Now, when you go into a bone marrow, the production starts with the multipotent stem cells now becoming committed megakaryocytes. When these committed megakaryocyte progenitor cells mature further, they form megakaryoplasts. Then it continues to the immature megakaryocyte, then to mature megakaryocytes. from megakaryocyte stage, there is, in simple terms, the platelets can come out of the bone marrow. But in coming out, it can't come out as megakaryocyte. So they are fragmented to be able to pass through the passage allowed for release of cells from the bone marrow. So these megakaryocytes become fragmented, and then we have the platelets as we see them in our films. So platelets are actually fragmented megakaryocytes. Megakaryocytes have nucleus. They have all other things that any other cell have. But one typical thing we want to recognize between platelets and RBCs is that at their mature stages in circulation, they both do not have nucleus. All right, they both do not have nucleus. All right. Now, when they are released into circulation, how many days do they spend in circulation before they become senescent? About 7 to 10 days, and they are good to go. Okay. Now, when platelets are released from the bone marrow, about 66% is available in circulation. That is about 2/3 of produced platelets are freely flowing in circulation. About 1/3 is stored in the spleen. Now, there are cases, like I mentioned earlier, if in adult life, the bone marrow fails to produce blood cells, the liver and the spleen takes up a secondary function of producing these blood cells. And when they take up this secondary function, they become enlarged. And the spleen being the storage site for platelets, when it becomes enlarged, it sequestrates more platelets. So when this spleen becomes very large, it takes up more platelets from circulation. So in those cases, you might be seeing very low platelets. So we'll be talking about platelet counts and what contributes to platelet counts being low or too high. And even if they are normal, there are times they are not functioning well. We'll be able to look at some of these things in this evening's lecture. So yes, when the spleen becomes very enlarged, which we call splenomegaly, there are more platelets that are drawn and stored in the spleen. So there are cases where the only remedy to such cases is to take the spleen out, a procedure we call splenectomy. You take the spleen out, and the spleen, the platelets, when they are released from the bone marrow, become freely flowing in circulation, and then the platelet count becomes normal. Platelets have no place to hide after the spleen is taken out. So eventually they become freely flowing, and then the count become normal, and then you have eventually, solved the problem of the thrombocytopenia. Okay. Now, when platelets are actually released from the bone marrow, they have a lot of things in them that help them to function the way they function. As I said earlier, since they are fragmented parts of the megakaryocytes, you will not see nucleus, so they are equally anucleate. In addition to all other features, platelets have alpha granules. These alpha granules help them in a lot of function. I wish we are doing a bit of coagulation. Although we know platelets have a role to play in coagulation, this evening's lecture wouldn't look so much into coagulation. I actually did not prepare to take you on that path in this evening presentation. I will just look briefly at some of the things that pertain to platelets and their function. So let's take on this slide. Yes, so alpha granules help the platelets to function well. There are certain membrane receptors like the GP1B and then GP2B3A that actually help the platelets bind to function the way they function. So in my preliminary introduction, I should have walked you through the functions of platelets, but that would have been too basic. Functions of platelets, we will be talking about to help in clotting, to help in the coagulation cascade, all of those things. So at a point, you realize that when there is a cut in a vessel, collagen is exposed, and then platelets become activated. When they become activated, they are attracted to the site of injury. When they get to those sites of injury, they become, like I said, activated. Some of the content they release are these granules that is in them. Now, on the membrane of the platelets, there are certain receptors that they use to bind to each other and bind to other proteins. So the GP1B lyrase helps the platelets to bind to von Willebrand factor. The GP2B3A helps the platelets to actually bind one to one another. And then they actually form the clots that eventually stops the bleeding or prevents blood loss. Okay. All right, so let's go and look at the nature of platelets as we see them in our films. The normal platelets look in size 2 to 4 micrometers, and they are anucleate disc with fine purple granules. Some of the abnormal findings you find on the film are giant platelets that come with Bernard-Soulier syndromes, or somebody recovering from ITP, idiopathic thrombocytopenia. In cases where you have EDTA artifacts, there are times you also have clamping of the platelets. In a film, you might sometimes see satellitism of the platelets around neutrophils. Then also, there are times you see platelet fragments. I think I have to be please allow me some 3 minutes. Let me get some water. I'll get back shortly. Please, I'm back. All right. So in our walk through platelets, their structures and functions, we mostly talk about some of the diseases associated with their structures. And when we are talking about functional defects, most of you might have heard this disease conditions: Glanzmann thrombasthenia, that has to do with the marker I mentioned earlier, glycoprotein 2B3A. We have Bernard-Soulier disease. If your platelet is not able to produce this GP1B, that's the disease condition you always get. We have storage pool defects and some acquired defects that has to do with drugs. All right. Okay, so okay. I think I have to this. Please, I would plead with you to look at this slide very well. I'm not sure this is my final slide. I think I'm projecting an earlier slide I started working on with you. So please give me 1 minute or some few minutes. Let me try and recover my finalized slide. It's as though my slide is disorganized a bit. Okay. Please and please.
Okay.
Hello.
Hi.
Okay. I'm still having challenges with recovering my final slides, but I've gotten something on my phone that I want to continue with. So I'm trying to share the stuff that I have on my phone. Then we can have an interactive session from this now on, this time on, and then I'll just bring on Dr. Alote to help me finish it up. This has never happened to me, but it's happening now. So I have to adjust in a way. iPhone share. Please, can you see my phone? Can you see my phone screen? Can you see my screen?
It's now loading.
It's loading. I don't know why. Wow. Okay, let me start something while I wait for the screen to load. All right, so let me calm down and be a bit more practical. So in our day-to-day running of cases in the hematology department, mostly in this automated era, we actually do our platelet counts using the hematology analyzer. And in doing so, I think earlier in our lectures, one of our resource persons actually walked us through automation in hematology. And with the little knowledge I also have, the primary mode of analysis of platelets in the hematology analyzers we have is through the impedance method. And in the impedance method, cells are actually allowed to go through an aperture, and then their sizes are used to categorize them. So in using their sizes to categorize the cells, platelets become the smallest, then the RBCs, then they look at the WBCs, which are the largest. So in analyzing platelets using impedance method, there are ranges within which platelets must be counted. And that range has to do with the size. So we have platelet count happening between 2 to 20 femtoliters. Apart from these ranges that we have, there are discriminators, lower discriminators set to regulate the nature of the platelets that are being counted, and there are upper discriminators set to regulate also what is to be excluded or included in the platelet count. Now, reason is that there are times that you have other structures that have similar size like the platelet. So if you have EDTA particles, if you have background particles that have similar sizes like the platelets, they'll be counted in your platelet count. And that may not augur well for your platelet count. There are times you also have RBC fragments that present through the aperture when you are using the impedance method to do your count. And then these fragments from the RBC also present as platelets when you are using the impedance method. So this actually has to be corrected. And in the correction of these limitations that has to do with the impedance method, there came the optical method in counting platelets. So in some of the analyzers, you see that when you are having a problem with your platelet count, you may switch to the retics mode, which was modified to count retics. But when you use that mode with the RBC parameters or with the other parameters of the FBC, you see that your platelet will now be counted in the optical mode. And when you do that, they are counted, without only paying reference or paying attention to their sizes, but also their structure and then their nature of scattering light. So that is used in counting them, and the count in that mode is corrected. Now, I came across a typical case one time where FBC was run with retics, and then the platelet count was very, very low. And I was a bit inquisitive, and I went to run with a normal mode without retics. What I found was very surprising. If I remember the figures carefully, I think with the retics mode, we were having about 11 for platelets. But when we did the count with the impedance, the normal FBC mode, we had about 315, which was actually a normal platelet count. Now, what was attributing to that? We realized that there was a problem with the reagent that was being used for the retics. And that reagent was brought earlier that morning. And when, through my inquisitiveness, I discovered that no, the impedance mode or the normal FBC mode was giving us a normal platelet count as compared to the retics mode. We got the problem identified, and then we got that reagent out of board and we replaced it. So this version or this section of the information I'm sharing with you is just to let you know that the machines are there to help us, but we also have to understand what the machine is doing, so that when the machine is not performing well because of some of the input we give the machine or because of technical hitches, we will be able to pick them up and resolve them. In fact, I hope you have learned something from what I just shared. Please, I want to hear, I want to get
Yes, please. Yes, please.
Okay. This my phone screen sharing seems not to be working too. Wow. What's happening this evening? Okay. Please, I think I have to work on a certain settings to be able to get this through smoothly. Please give me some time. Oh.
All right. We appreciate the problems. I keep going on and off myself. So
Yes.
per what
Dr.
you
Alode.
said,
Please come in.
yes, from what you said, a little have learned is that we shouldn't forget the focus of our training, in that we want to be able to evaluate peripheral blood films. Now, we want to look at platelets. That is what we are looking at. And from the experience you had shared, what do you think we should do if we experience a thing like that? We need to roll out a thin film and be able to see whether the platelet count we are experiencing is not artifactual. Because on morphology, we are able to look at the platelet count and decide that the platelet count is adequate, is raised or increased, or it is reduced. How do we do that? We compare the number of platelets with cells. That's how it's done. We see about approximately 20 red cells. So that's the comparison we make for us to decide that, oh, yes, this number of platelets we are seeing is okay on the film, but it is not okay on full blood count. Then we can go back and find out what is the cause of the fact that the full blood count is giving us a low platelet count, whilst we are getting adequate platelet counts on the peripheral blood film. And the reverse is also true. We are getting a high count. Then we examine a film and the proportions tells us that the platelets are reduced. So then it means that something causing the platelets to go up. Then we begin to look at the histograms. If there was a group of slides I shared speaking to the limitations of the analyzers. If you go back to it, you realize that fragmented red cells can cause a problem with the platelet histogram. You end up getting very large platelets because it will be on the right-hand side of the platelet histogram. Tells you are getting large platelets, whilst in actual fact, you examine a film and there are no large platelets. So then what you'll be looking out for would be to see whether you find fragmented red cells. And so these are the experiences that we need to bring to the work that we perform. We shouldn't forget that our focus is to be to evaluate film. So whatever we learn concerning platelets, concerning red cells, containing white cells, how are those things going to help be able to do evaluation of blood smears? And so here, Dr. is drawing our attention to the numbers. So count is one thing that we have to be wary of. And for us to be able to do the count properly, like it's said in some analyzers, the optical counts of playlists. As a matter of fact, before these things were developed, the optical thing, sometimes clinicians a manual platelet count. just because for some of these malignancies in hematology, giving drugs depends on the platelet count because you don't want a patient to bleed from every orifice. So you are asked to do an actual manual platelet count. Thankfully, we have analyzers that can do upscale count. And therefore, we are. Are you ready, Emmanuel? Are you set to continue?
Yes, Doc. The problem I am
Okay, so
having,
come then. If you are set to
yes,
continue, just come.
yes. It's looking as though it's since I am online, I'm not able to. I don't know if I have
Use
to
the
ask
phone.
permission.
It's going to be the same unless you make this also double 60.
Say again.
Find two fractions.
Sir Latif, please, you are saying something. I don't know if I have to restart my machine or because the slides I'm supposed to present were fine-tuned from what I had I was using earlier, and the one I was sharing with you is very scattered, very scattered. I can't use that. I had the fine-tuned slide had the histograms in it, and even the graphs where you see the flags, where you see part of the graphs not touching the lower discriminator to the base, and then the upper discriminator to the base, and how you troubleshoot those ones. In fact, I don't know what's happening this evening, but
Hello, boss.
I'm not able
Dog.
to get those.
Hello, dog.
Please talk to me. Yes.
Okay. I think when you go off and you restart your machine, you can come back. And I wanted to share a similar thing that happened in 2014. Some portal. So we ran the same thing, and then the retics was giving us. We ran the same figures, like the way you see your own data. It's retics. The retics was giving us a normal plate. And then when we ran without retics, it was giving a low platelets. So with that, we also came out, and then we didn't validate the results. We didn't send out the results. We also have to troubleshoot our reagents. And then so by then I was a junior. So I brought out, my boss was a bit confused. I brought out that let's change all the reagents, because it was a trend around that time. So I said, let's put in a new reagent and see whether we'll get the same thing for these patients. And lo and behold, when we changed the reagent, we were getting a good result. It came out as your own, that the platelets was actually low. So sometimes we don't actually agree with machines too much. Based on that, like what Dr. Alote was also saying, we did a thing. That's where we realized that no, the machine is giving us something wrong. So we need to do troubleshoot. So it's good to do all those troubleshoots, and then let's do troubleshoot on your laptop. So you restart it, and then go off and restart it, and let's see whether it will work or not. Thank you.
Okay, thank you.
Oh, it's all quiet. I think he's working it out, right?
Yes, he's working on his laptop, so we can
Yes,
we can
please. We are
be
waiting for
having
him.
a discussion.
He's working it out.
We can have it. We can be having a discussion together.
Yes, whilst it's at it,
Whilst
we can still be talking. When it comes to playlists, the numbers are very, very, very important to us. You know, player count is one of the things that we can easily what's the word? Get it wrong, you see, because if we have low player count, we must first of all check our samples and see whether we have done the right things before we ascribe any use of a smear. Because if there is what they call platelet satellitism, platelet clumps, they all affect the count. And so once we are able to do all these things and we know that we haven't done anything wrong, indeed, EDT has a clamping effect on platelet as well. EDTA. So that shouldn't be lost on us at all. It's why evaluation of a film becomes very, very important. Nothing is wrong. Just the use of EDT and you are getting low platelet numbers. And so you find out on peripheral blood as platelet clumps. So if you have done all the things right, and we still have a low platelet count, that is where we begin to think about disease condition. Did I hear someone say something? Is someone trying to say something, please?
Yes, please.
Your voice is
Very foul. Your voice is very foul.
So it's not consistent. You mean my voice? Hello? You mean mine or his?
The other person wants to say something.
Oh, okay. Okay. Yeah, I couldn't hear him either. And so for us, when it comes to the numbers, we must rule out all the other possibilities that can cause us problems with the numbers, including, dust particles, electrical noise, etc., etc. They are all there to think about pathologies. And when it comes to pathologies, we already know the different things where we have problems with platelet numbers. For example, he talked about hypersplenic function. Spleen is enlarged. We know normally the spleen has a storage function where it pulls a third of the platelets and stores it. But when there is hypersplenism, the spleen is overworking, is pulling platelets, and some of these things will be seen at the clinic. You'll be told there's splenomegaly. If there's splenomegaly, you are told there's splenomegaly and you are seeing that the platelet count has been affected. Then you know that, well, it is the reason the platelet count is affected. But indeed, if you examine a film and you see that the platelet count is not affected, then it means something else is going on, because in the proliferative disorder of platelets, which is essential thrombocythemia, the platelet is very, very, very high. And so that's how we look at these pathologies. apart from the numbers, the thing that we'll be worried about will be the size of the platelets. We are seeing giant platelets, and then we know it's a coagulopathy. We are seeing large, bizarre looking platelets, and we are thinking that is spastic syndromes, or the proliferative disorder in case of essential thrombocythemia. And then the next thing will be the function. You know, the numbers may be there, but the function is poor. Platelet function is poor. And then that delves you into especially aggregation. If you had been able to project the slide, he was going to talk about, you know, some of these things, and show us the role of the platelet, the function of the platelets, and how it does its work and all that. And so for us, because we are already scientists, I would urge that, so like I said before, the kind of method that we have to employ here has to be the one that is give and take, one that does not depend on the teacher or the lecturer, the one presenting. At this stage, the presenter is a facilitator. And so we expect that colleagues would have know some of these things already. And so we are just bringing to their attention and just being intentional about it. I keep saying that it's just bringing your attention to some of these things intentionally sometimes. And so the point is that we have to be very, very intentional in the things that we do. And I keep saying that we must, it's part of acquiring knowledge. If we have to do anything, so hearing from other colleagues. Thank you. Before, there was a gentleman trying to tell us something. If he can come again, we'll be happy to hear him.
Hello.
Hi.
Good to have you back.
Thank you. Doc, it's as though all my IT gymnastics couldn't help. But in my preparation, I actually took some screenshots of some vital information I came across. So I've quickly put that on the slide, and I'll want us to go through it. Then I'll ask permission to adjourn this meeting. If the opportunity is given me, I will try and work on a new slide, and then I'll come and actually present. It's as though instead of saving my fine-tuned slide, I actually didn't save that one. Rather, I saved the old one that I was supposed to discard. And that has actually flipped everything on the bad side. It's actually a humbling moment for me right now. But if you can make me a co-host, that's Sir Latif, please, if you can make me a co-host, I have something small to share. Then we can bring this evening's meeting to a close. It's a Latif. Please, can you make me a co-host?
Hello, CPD Council.
Hello, Dr. Alote. Please, can you hear me now?
Yes.
Okay. So what I wanted to add to what Dr. Alote was saying concerning the platelet issue is also inadequate mixing of sample can also have effect on platelet EDTA ratio. So if sample is not mixed very well, it's also have effect on that. Our QA and our QC in our either sample taking, sample mixing also can have effect on the platelet that we also subject to the machine as well. It's not everything from the machine that comes out that we 100% have to accept. Sometimes we have to also do our own work to see whether the machine has given us a good result or not. That is what I wanted to add up to what Dr. Alote was actually saying. Unfortunately, my brother, Dr. Ima, troubleshoot couldn't work, so we'll be glad to see what you have for us. Thank you.
Thank you.
Thank you so much. Thank you so much. Thank you, Prof. Alote, for coming through for me. This is something that has to do with the histograms. Prof. Alote will actually help us marry all these things to the film comment, what we are going to be seeing on the films, and how this interplay with our ability to validate even the FVCs and then troubleshoot with the films. Okay, so like I mentioned earlier, in measuring our or in counting our platelets, using the impedance method, there is a consideration of size. So platelets are measured between the size of 2 to 20 femtoliters. Now, if you have particles like dust particles or some microbial contamination in your reagent, they are going to be counted in the category very close to the platelet, or in the lower size range of the platelet counting range. Some of these interferences may come from the dust, like I mentioned earlier, or contaminated reagents. There are times EDTA particles even are counted as platelets. If they are not well troubleshoot, if you are doing your QC checks and your background is not well checked, these things will end up interfering with your platelet count. So if you do your background checks and then it is clean, you are sure that these things wouldn't come, to affect your platelet count. So if you are having some counts that are around the 20 femtoliter region, or there is actually a right shift of the platelet graph, you, in addition to films that, the blood film that you can actually prepare and look at it and then really know what is happening, there are certain things that should be ringing in your mind even before you get to your blood film. Some of these things is, are there fragments of RBC that might be contributing to this right shift you are seeing? Are there WBC fragments that might be contributing to this right shift you are seeing in the platelet curve? These are questions that should start ringing in your mind even before your film is ready for you to observe. Now, there are times that the platelet histogram is skewed to the left. Usually, the curve should be between the lower discriminator and then the upper discriminator. When you have that, your curve, your I think it's the Gaussian curve we call it. It's not all that, for the platelet graph, it's not all that Gaussian, like a perfect bell shape. It is almost, shifted to one side. But in the middle of that is one parameter that we actually use in knowing if our platelets are having, a good shape, or they are having a larger than normal shape, or they are having a lower than a normal shape. And one of those parameters is your MPV. So the mean platelet volume. Just in the same way we have MCV for RBCs, the platelets also have MPV. And then the middle of that curve that you see should land you on the MPV. So there are times the curve shifts to the left, meaning it deviates from that expected MPV you are supposed to see. Then you start asking yourself, what might be the cause of this left skewed graph? Okay. So, like I mentioned earlier, your MPV is your mean platelet volume. Your mean platelet volume. And that's the average of the volume of the counted platelets that you have. And it's similar to your MCV in the case of RBCs. If you have reactive thrombocytosis, where the platelet count is high, there are times that your MPV is still normal. So in the case of RBCs, where you have sometimes some conditions that increase the red cell count, there are times you still have your MCV being normal, because the size, we are talking about the size here, the size is normal. Okay. In some malignant conditions where you have thrombocytosis and the platelet count is high, there are times the MCV2 is high. When the MCV is high, what are we referring to? The mean platelet volume is high. That means you have larger than normal size of the platelets. And mostly, you'll be seeing giant platelet. Having removed all other interfering factors, you'll be seeing giant platelets if you look at your film. All right. So if you have increased MPV, some of the things you can start looking at or you can start questioning is the person having any of these conditions? One, has the person gone through splenectomy? Is the person having any malignancy? Example, chronic myeloid leukemia? Is the person having myelofibrosis, ITP, or sickle cell anemia? I'm sure Dr. Alote would take turns to walk us through how some of these things present with very high platelet, sizes. I will reserve that for him to do. I wouldn't want to go into details because I might be limited in knowledge, in practical knowledge, to be able to explain these things. Now, when you have very low MPVs, some of the things you can start asking is, thinking about is hypersplenism. So I explained earlier that 1/3 of our platelets are stored in the spleen. Now, if the spleen is enlarged due to a disease condition, due to maybe extramedullary hemopoiesis that is happening in the spleen, you realize that the spleen will be pulling a lot of platelets, like I mentioned earlier. When that happens, how does it impact on the platelet size? And here we are saying that in such cases, you'll be seeing very low MPVs. So if you do your platelet count, your FBC, your MPV is low, you can start questioning some of these things. In aplastic anemia, your MPV is low. In megaloblastic anemia, your MPV is low. In megaloblastic anemia, we are looking at your folate deficiency, vitamin B12 deficiency, alongside other things. In chemotherapy, your MPV will be low. Okay. Now, here we want to look at the platelet distribution width. Just the same way we have red cell distribution width that talks about the range, the variation in the size, the coefficient of variation in the size, or simply put, the variation in the size of the platelet, of the RBC. That's when we are looking at RDW. Here we are talking about the platelet size, the variation in the size. So you have maybe some small platelets all the way through to some big platelets. You can pick that from your FBC first. If immediately you pick that your RDW is high, that means you have varying sizes of the platelets in there. So you quickly prepare a film and then you want to assess the platelet. Then you can pass a good comment. RDW also could be expressed by drawing an arbitrary line on the height of 20. I think these are calculations that are done behind the scenes to give us the RDW values. Now, the causes of very high RDW, aplastic anemia is one, megaloblastic anemia is one, chronic myeloid leukemia is one, chemotherapy is another. Now, if you have platelet clamps and micro RBC or RBC fragment, how do they impact on the RDW? Because you have RBC fragments, which will be counted among the platelets. So you have a pool of the platelets being within their normal sizes, and then you have RBC fragments that are counted within that pool. So you realize that the sizes, the variation in the sizes will be wide. So if you have a very high RDW, you are going to start questioning these things. And immediately you prepare your film, you see that, oh, okay, this person might be hemolyzing. And for that matter, there's some schistocyte or red cell fragment in there that might be counted within the platelet. And that might be contributing to the high RDW that I am seeing. We have the platelet large cell ratio. Now, this is the large cell platelets. We also call them giant platelets. Now, if somebody had gone to chemotherapy, okay, where the bone marrow has been cleared through the chemotherapy, and then there are new cells that are being produced, you realize that there will be a certain pool of new platelets that will be produced. But then also, previously, the spleen might have also stored some platelets and have started releasing some of these platelets. Some of these platelets from the spleen would have a larger size, okay? And that can be graphically categorized and calculated. There are times too in the general thrombopoiesis process or in the production of the platelets, there are varying sizes of the platelet that are produced, like I mentioned in the previous slide. Now, there is the need to actually look at what portion of those platelets are larger than usual. You group those ones and then you take a ratio of that. So you group the large cells of the large platelets that you have over the total platelets counted, and then you find a ratio, and that also has clinical significance. Some of the causes of very high platelet large cell ratio is platelet clamps, like I mentioned earlier. So if you see a high PLCR, you should start questioning yourself. What might have contributed to that high level? Then when you make a film, some of the things you should be expecting to see are the platelet clamps or the giant platelets or the micro RBCs. So you realize that some of these things are running through even when we started talking about MPV. They are also here. When we were talking about RDW, we mentioned some of these things. Now we are talking about PLCR. So when you see these values being high, you don't just brush it to the side. You don't just go ahead and validate your RBC. It is okay. You can give it out. You have to go further to get a film, a quick one, and assess the platelets. If the only problem you have is with the platelet, you assess the platelet and do a comment alongside the FBC you are giving out. Okay. Thrombocytosis, that means increased levels of the platelet. There is a graph, a normal graph of platelets, but when you have increased levels, in fact, in the presentation I wanted to do, I should have been able to talk about essential thrombocytosis. Some of those things that actually cause high levels of platelets. There are times that you have mutations like JAK2 mutations that actually impact on the platelet. You have thrombocytopenia in some cases like that. But I like I said, I apologize greatly for that mishap. I'm just making do with what I have here. I know in good time we'll be able to have that presentation nicely. Please forgive me once again. All right, so thrombocytosis, there are times you have very high levels of the platelets and the curve will look, bigger than normal. All right. Like I said earlier too, you have thrombocytopenia in some cases and the curve will be looking smaller than normal. In that case too, you do a film to actually assess your platelets. Is it a true value you are seeing on the FBC? Then on the film, you can pass a comment. Is it mildly reduced, or it is markedly reduced, or it is just adequate? Then you are able to pass those comments alongside the FBC. This, I think we'll be talking about the flagging systems. So when you look at the original graph, the origin of the curve should start from the base. But if you have situations where the origin of the curve is not starting from the base, these are some of the possible causes. So like the background check you have done, there is a lot of noise in the background. There's a lot of particles in the background, perhaps from your reagent, perhaps from a diluent or from something. So that is interfering with the lower discriminator or the origin of the curve. Okay, so you have to troubleshoot that and then get it corrected. There are times they are not from any background problem. It's actually originating from the sample. It's a sample case. So there are times you have platelet aggregation. You have that challenge. The curve will not start from from the base. Cell fragments, these things we have mentioned them severally in this small presentation. Yes, your curve will not start from the base when you have cell fragments. Contaminated reagent, okay, here it comes. I've mentioned that earlier. High numbers of bacteria in the reagent. I think I mentioned that too earlier. Okay, so the next one is the other side of the curve that is supposed to end on the base again is not touching the baseline. What is the possible cause? This time round, you can start looking at platelet clamps. And where do you get this information from? The machine will just give you these kind of graphs and even give you some flags. But where you get the details of what is causing this problem is your film. When you prepare the film, then you are able to assess the platelet. Are there platelet clamps for sure? Yes, you see them and then there you go. You actually pass a comment, or if there is a way to correct it, mostly if it is an anticoagulant incompatibility, yes, several times Bosalute has mentioned, you use a different anticoagulant bottle, and then you are able to correct the clamp. And I know most of us might have done these things practically in our various facilities, and then we have gotten the problem resolved. Are there giant platelets? If they are giant platelets, then you report them as the ones contributing to the kind of curve you are seeing. Are there micro erythrocytes? If they are there, then of course you can do a corrected, you can pass a comment and then add it to your FBC. There are times to a curve that is supposed to be looking Gaussian, skewed to the left. You have now a bimodal curve, a curve that
we are quite visual.
I'm actually now joining on my phone. I don't know what happened. This machine is playing tricks with me this evening. This machine is playing tricks with me this evening. Anyways, I think I was almost done with the slides I was showing. Please, can you hear me? Can you all hear me?
Yes, please.
Yes,
Okay.
we can.
Sorry. Slide, the machine just went off. Anyways, okay. So I was talking about the bimodal nature of some of the curves we see. Sometimes when a patient is recovering from chemotherapy, like I mentioned earlier, you have some platelets coming from the spleen, and then new generations of platelets that are being produced from the marrow fresh. In that case, you can have a bimodal type of curve on your platelet histogram. In a typical case where you have platelet transfusion, yes, you can also have bimodal curves or histograms. So these are some of the cases where your histogram or your platelet histogram will be giving you information that would urge you to want to prepare a film to confirm that this thing is really looking this, and this is the true picture, or the machine is limited and then you are helping the machine to actually give an exact diagnosis to the patient. So with having said this, I want to end it here and then give the opportunity for all of us to add on to what I have said so far. Bosalute, please, this is the little I have to share with all the technical challenges I had. Please forgive me. I'm going to work on it. And then if given the opportunity, we'll reconvene and then I'll do a full lecture on it. Thank you.
Thank you. Notwithstanding that, you have done a very good job. I mean, I think you touched on almost everything that comes to mind. Probably, except we didn't talk about platelet crates.
Yes.
On your FBCS platelet crates. Yes.
Yes.
So folks should take notice and be able to speak to platelet crates. Apart from that, I don't think we left anything out. Probably these challenges, because they came up, may have prevented you from throwing the way you want to flow. Apart from that, there's really nothing to hide. Despite all the challenges, it's been a well-presented piece. Thank you. So colleagues will now have to come in and
yes, please. Please, everybody should be candid enough and then make your contributions. I am just one of you, and these challenges have come today. But surely I'm promising you a better presentation next time. Please, everybody should feel free, bring your contribution on board. Thank you. Hello. Okay, so I'll do it in Dr. Degenu's way. Please, can I mention names? I can see
please mention names. So we have been mentioning my name all the time. So go ahead and mention other names.
Okay. I can see Mr. Emmanuel Adi. Please, what have you come across in your lab with regards to platelets? What do you want to share? Please say something. And we are 14 now. I don't expect the number to go down. Each one of us will contribute something small, please. Provided we've not logged on. And then,
I think that.
Please, we are listening.
Just the histogram with the ending part not ending on the x-axis or something. I think that's what we've been having that. But now we weren't doing the smear back then. That was why they got us to join to learn something from there and then maybe implement it. So I think we are now learning something new here. I think that's what I would say from
okay. Oh, then that's great. If after all the challenges I've been able to give you a new idea, then that's great. Yes, Mr. Safo, please take the floor.
All right, thank you so much for the opportunity. There is something I want to ask and then understand, okay? So concerning the platelet parameters, the platelet and its other parameters, I want to know that must there always be, before you can check for the PDW and then the other things, must platelets be either high or low before you can consider or make MPV, the PDW significant, or independently, platelet can be normal, but then the PDW can be low or high, or the MPV can be low or high. I don't know if you get what I'm trying to drive.
Yes, I think I'm getting it.
Yes, so just want to know that can MPV single-handedly on its own be let's say pathological or very classical or significant without platelets being low or high?
Okay. Please, I wouldn't be the only one talking. Who wants to take a bite to this question? Yes, Abdul Waris. Doc, please go ahead.
All right. Good evening, everyone, and thank you for the presenters for such an insightful presentation. Please, even from today's lesson, he did mention of, besides the quantitative platelet abnormality, where you can have low platelet count and then high platelet counts, he did mention of other conditions such as Bernasoli syndrome and then Glanzmann thrombasthenia. In Bernasoli syndrome, you realize that the abnormality, it has to do, the abnormality involved, it has to do with the size and then functionality of the platelet, where you have very big platelets. Then you also have conditions such as May-Hegel anomalies, in which you have giant platelets and other things. So you might not necessarily have to look at only the platelet count before you consider the other parameters. For example, if the MPV, mean platelet volume, is high, it is telling you that you have larger platelets, and that can give a clue to conditions such as the presence of May-Hegel anomaly or the Bernard-Soulier syndrome. So you must not necessarily have low or high before you consider the other parameters, because the size can also give you a clue to the presence of other platelet abnormalities. Thank you.
Wow, that's a great one. Exactly so. Exactly so. You know, in the case of the RBCs, and then the RBC indices, they impact on each other. They impact on each other. But in the case of the platelets, there are certain functional defects that may not affect the count, but will affect the other indices. And if you pay attention, you'll be able to pick them up. So he mentioned some 3 cases. These are functional defects and structural defects. They might not necessarily affect the count, but you are sure to pick it up in some of the indices. And if you are led by the indices and then you prepare a film, then of course you can, with the film, be laying your hands on the particular causing agent or causative agent. That's a good one from Dr. Abdul Waris. We appreciate your contribution. This is an interactive class indeed. Please, a hand is up. Dr. Safu, you can unmute and then go ahead. Or is he an old hand? Okay, yes, go ahead.
So it has been answered perfectly. Thank you so much. So I'll put my hands down.
God bless you. All right. I have. So I'll be calling Dr. Daniel Senu. Okay. I think Dr. Waris is back. With your hand up, please unmute and then go ahead.
All right. So I think I've shared this case before. We have one of, in fact, the person was even a co-worker whose platelet counts was always around 1,400 and something.
Wow.
Yes. So I was in one of our satellite clinics, and he came to do an annual medical checkup. Then after running his full blood count, noticed that the platelet count was around 1,400 and something. Then some of the parameters within the indices were not shown. Then when I also look at the numerical data, there were asterisks attached to most of them, especially the platelet count and then some of the indices, including the RBC count. But that day, fortunately, I have control, so my controls passed. But I was still trying to be a doubting Thomas. So I had to take, that was the first sample I ran for that day. So I had to take a sample from the previous day, and I ran just to be sure if my analyzer was okay. When I ran, I had a very normal platelet count. So I also went to the electronic, our EMR. Then when I trended, I realized that that was not the only instance he had such a very high platelet count. So because of that, he was even referred to a hematologist who requested a blood film comment that was done at one of the best labs in the country. So they confirmed that the platelet count was actually very high. But I still wanted to also see for myself. And when I prepared a film to review the slide under the microscope, what I saw was very nice. Almost all the cells were ellipticized. They were microsphericized and then some fragmented cells. But the platelet count was very normal, very, 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 very normal. But that lab reported that the platelet count was actually very high, but I was surprised. So I had to send a sample to our main office where we had the Sysmex XN350 that does the reticulocyte count. And when we switch to the reticulocyte plus FVC mode, which actually uses the optical platelet count, the platelet count was corrected to 310.
Wow.
Yes,
Wow.
but because the platelet count was such high, the hematologist was querying essential thrombocythemia and even went ahead to request for JAK2 mutation. So unfortunately, the guy couldn't do the JAK2 mutation because he said he went to ask for the price and they said it was like 5,000 and above. So I told him that, well, but what I have seen, I will draw my boss's attention so that he will do the film comment by himself. And he actually confirmed that it was erythrocytosis and the platelet count was very normal. We had to communicate to the hematologist about the findings, and then the guy was discharged. So you can imagine the trauma that the person was going through because they thought he was having a very severe condition that will put him at risk of thrombosis. Assuming he was able to afford the 5,000 to go and do JAK2 mutation, only for them to say JAK2 mutation is negative. You look at the economic aspect. So I'm just sharing this for us to see the need for us to always confirm our findings under the microscope. Even though analyzers have made the work very easy for us, it's still incumbent upon us to still put the work of the analyzers to check. Apart from misleading specialists to request for unnecessary tests and the economic aspect of the findings. Yes, thank you.
Wow, that's a powerful one. That's a powerful experience right there. And it will be put in our knees. In any time we are actually approaching this thrombocytosis cases, we don't just do it in isolation without looking at the films. The film can give you a very, very, very straight diagnosis, straight differential approach to the diagnosis. And then if in the absence of the film, you might be subjecting the patient to a whole lot of stuff. So yes, hematologists, yes, as hematologists, our generosity with our films, when we see, things that are not normal on the FBC, will go a long way to help our patients. Yet again, we are actually preaching this message against the constraints we have in our health systems, where it is as though some category of people are the ones called to be doing film comment. All these things, we are praying that as we polish ourselves, as we know what we are about, when we comment, we pass a comment on an FBC, we pass a comment on any report or any film, they will know that these comments are not supposed to be taken lightly. And when we get to do this, and then we are, preferring solutions to, most of the patient problems, very sooner than later, will become part of their consultation team. And that time is not too far from here. And programs like this, I believe strongly, is one of the pivotal programs that we need to actually push this professional capacity building to the very next level. Thank you so much, Sir Waris. These experiences you are sharing with us are very practical and they are helping us. Please, I'll continue with the name calling. Yes, I mentioned Dr. Daniel Senu. Please, your contribution, your question, your observations. Please feel free to unmute too. Anybody who wants to make any contribution can unmute, please. Dr. Erico say, today I've not heard your voice. So. Dr. Emmanuel Notte.
Yes, Doc.
Please talk to me. Talk to us.
I think so far so good. At least some senior colleagues have shared some experience, which in my facility we've encountered similar instances. Then as it was switched on to the platelet O count, everything was corrected to normal for the platelet. Thank you.
Oh, okay. Thank you so much. Thank you so much. Dr. Prosper Malema. Please, did I get it right? Sir Prosper.
Doc. Hello, Doc.
Yes.
Good evening.
Good evening.
Sorry, I was trying to unmute. That's why the delay came in.
Oh, please feel free.
All right. Yes, so once again, you've done a human job. Congratulations for impacting this wonderful knowledge into us this evening. So I think contributions from colleagues has also touched on some of the challenges that we have in our various facilities. In my case, with regards to platelets to be specific, initially when I came to the hematology unit, the major challenge we were having was the sample to EDTA ratio. For one way or the other, there was this belief that once the machine is able to aspirate an amount of blood, when you are to do full blood count, once you get something small for the machine to be able to aspirate, you are good to go. So the sample EDTA ratio was a problem in my facility. So it was through a presentation like this that I got to know that once the sample EDTA ratio is not respected, the platelet count would be affected. So we try to put measures in place to make sure that as much as possible we meet the sample to EDTA ratio, and we have observed some improvement. Yeah, but it's the citrate tube that we've never had the opportunity to have citrate tube, so that we'll be able to, in some cases where there will be a need to retake a sample into a citrate tube to correct the platelet value. We haven't been able to do that for now, which we are working very hard to be able to get the citrate tube available, so that whenever possible, when it's needed, we would repeat the sample into a citrate tube to have an accurate platelet value.
Exactly.
So that's what I have to share from my end. Thank you very much once again.
Thank you so much. To add to what you have said.
Hello, Doc.
Yes.
Hello, Doc.
Yes.
I was actually in the house, so by then I was driving to the house. So now I can contribute a lot. And I say something about Prosper's contribution you just submitted.
Okay, please go ahead.
My brother Prosper, I think the EDTA, we have the 1 ml type. That's for the pedics. Okay. If you know that this, you will not be able to get enough for the children, you get the children's one, the pediatrics ones that you use. And that one will help in aspirating so that the ratio between the EDTA and the sample will be equal. But if you are using the 2 ml and the 4 ml, sometimes it have effect on the readings, but we may not know. These are some of the things that helps us. These are some of the trainings that helps us to enlighten us when we wanted to run samples for patients. I always say that one day you'll be a patient. Don't say that you are working. So, but definitely one day you also be a patient. Whatever you measure for a patient will be measured to you. So at my side of work, Abdul Waris, we work in the same hospital. Whatever we measure for a patient, we measure for ourselves. So QA and QC is one of the key things in wherever we are. We should pick that thing as a habit. Wherever you are, make sure that you practice the correct things so that the result that comes out, you chest out and say, that's the confident results. And when they call you for something, you'll be able to answer. Let me just give a scenario on something. One time, there was a night group who ran a sample, and then the WBC of the child was 8,000. Yes, it was 8,000. So in the morning when I came, and they said, oh, they ran a WBC of this child, and the FBC for this child, and this thing went to 8,000. They ran it about 3 times. I cross-checked from the machine, and I'm saying that they are running 3 times. And then I said, okay, let me run control and rerun the sample that was run. And I said, no, can I call the patient? The patient is actually on detention. So I called the mother and spoke with the mother. Please, we want to take another fresh sample. I'm begging you. We are seeing something, and they wanted to verify. So we wanted to pick a fresh sample. And the mother said, oh, why not? He agreed. And then OA30 control was picking, and then I picked the sample, we ran it, and the sample came out to be 400. What went wrong? No medication was given. Only IV para was given. Okay. So sometimes some of the things we need to know our QA and QC sample errors and other stuff. So Prosper, I'll urge you that you tell your facility that this will help you and this will give out a good result. And then that will bring a lot of patients to your facility, and you get 13th month salary as well. Thank you.
That's a powerful one, Doc. That's a powerful one. Yes, I'm sure Prosper has heard you.
Yes, very well noted. Yes, just to also indicate that, yes, the pediatric EDTA chief, we do have it for children. So my contribution was also in relation to adults where we use the normal EDTA chief, and yet we are not able to get the appropriate sample volume for our ABC analysis. But his input is very, very well noted, and I do appreciate a lot.
Great.
Thank you.
Okay. I want to ask a question. How does difficulty in getting a blood sample impact on the platelet count or the platelet nature? How does a constrained phlebotomy or a difficulty in sampling, how does it impact on the platelet count or the platelet indices or the nature of the platelets that we would have on the film? Please, anybody to share. Please unmute and go ahead. Yeah.
Okay, so I think when you encounter a difficulty in the phlebotomy procedure, it means that it can lead to activation of platelets. So that can lead to platelets clamping. Then when you are to analyze on the automated count, you can see that platelet count will be low. And because of the aggregates and then the clumps, it may also affect your MPV. It may also be high. This is what I can say about it. Thank you.
Powerful. Powerful. How are you able to differentiate these from other causes or sources of platelet clumps? Please, did you get my follow-up question?
Yes, please.
Okay. Anybody to take it?
Please, the question again.
Okay, so I first of all asked, how does the difficulty in sampling affect platelet count or the nature of the platelet we see on a film? And Dr. Waris mentioned that yes, immediately you are having difficulties or your phlebotomy process is prolonged, you would have activation of platelets, and by that they would eventually form clamps. And when clamps are formed, it's either you are having it reflecting in the MPV or the count itself. Now, when he said it will affect the MPV, he mentioned that these platelet clamps can be seen if you do your film. Now, my question is, how are you able to differentiate this form of clamps from platelet clamps caused by other causes or conditions? Please, do you get my question?
Yeah, it's clear, but
So I think when if you make a thin film to observe under the microscope, if the platelet loop, the aggregates or whatever you are seeing is as a result of a traumatic phlebotomy, I think you may see fibrin strands too. But in other causes of platelet aggregation, such as EDTA incompatibility or platelet circulatism, you will not see those ones. But if it is as a result of platelet circulatism, you see the platelets forming a rosette around neutrophils. Thank you. This is what I have.
That's a clear one. That's a clear one. Okay. Mr. Adi, you want to add something?
No, please.
Okay. I think we have spent quite some good time together this evening. I'm sure we've had contributions from almost everybody this evening, and I do not take it lightly at all for making this evening's interaction a good one. Besides all the technical hitches that came my way, you have stayed on patiently and have been able to put some information across. Thank you so much. I appreciate you all, and I'm sure that in fact, I'm seeing us, becoming very strong, forces when it comes to film commenting and hematology. When it comes to the hematology side of our lab work, I think the team here, at the end of the day, we are becoming very formidable in our diagnosis approach and everything. I appreciate you all. Please, is Dr. Alute here?
I was
think
lost.
just
Now I'm found.
Thank you for coming back. Doc. Yes. I was just giving my final remarks, then I hand over to you.
All right, please go ahead.
Doc, please, I'm done. Please, over to you.
Okay, so thank you very much, Doc. And for me, I think I have enjoyed this session more than any of the session. Then there's one thing I quickly want to add, that all along I've been saying that we need to fight with knowledge. Yeah. That is all we have to do. So I'm very, very happy about the experience that was shared by Dr. Waris, right? That's the name, right? Yes. About a client whose player count was over 1,000 and was diagnosed as a possible, ET. That turned out not to be so. When you went through the motions and you made the corrections and you found the right thing and you placed it before them, they didn't reject. They accepted it because you showed knowledge. We can do same. Not too much about myself. I used to do consultancy work for MBS Lancet. I did the same thing as a lab physician who calls himself a hematologist. We sit in the same seat. He gets up today, tomorrow, I sit in there. The same thing. And so there is mutual respect. If you show knowledge, formidable knowledge, that you have knowledge, they will respect you. So please, let's do this with knowledge. Thank you. It's late.
Thank you so much, Doc. You've always been with us from day one, and your supervisory and guidance is really, really growing us. We appreciate you so much that you are able to pour your knowledge into us and impact us. We appreciate you so much. Without much ado, I would want us to adjourn this meeting. But before that, Mr. Latif, please, any announcement
from CPD?
Yes, please. Yes, please. Please, any announcement for us? Anything we should know going forward? CPD Consult. Okay. So I don't know how we are going to end this lecture though, but
yeah. Look, I think we should end and reconvene next Monday. Thank you.
Next Monday. Okay. Thank you so much. Thank you. I don't know who will be able to end the lecture, but I think now Mr. Sam,
we can all leave. If they are not there to end it, let's all leave. Maybe when
we leave. Yes. We probably have overstayed some 20 minutes or so.
Yes.
And so let's leave and call it a night. It's been very fruitful. I have enjoyed myself. Thank you. Good night.
Good night.
Thank you. Good night too.